So now we are going to read about disorders of atrioventricular mode. Let's start with some basic physiology, some basics of the atrioventricular mode. So AV node is actually a subendocardial structure. Subendocardial structure. The next point is the location. So the location of the AV node is it is present on the in the apex of the triangle of top. So if you don't know what is triangle of Koch, you can see this here there is a triangle and there are three boundaries. Of course, anteriorly you are finding tricuspid valve annulus. Posteriorly there is coronary sinus ostium, and superiorly there is tendon of Rodaro. So these are the boundaries of triangle of Koch, and at the apex of it there is AV node. You can see here this is the AV node. Next thing is this AV node has very good autonomic nervous system supply. Very good autonomic nervous system supply. That means it has both sympathetic and parasympathetic supply. So anything that causes a disturbance in the sympathetic or parasympathetic stimulus, it can actually affect the AV node. We'll be seeing all those things later also. Now, next thing is what is the blood supply? The blood supply. Blood supply is through the AV nodal artery, and septal branch of LED. That is S1 of LED. In the previous lecture, in the lecture of ECGs in MI, I have discussed about this. So whenever there is a occlusion in the LED above S1, they may have associated AV nodal dysfunction. So the reason is this, because S1 is supplying the AV node. The next thing is there is one concept about the AV node that you have to remember. That is known as decremental conduction. Decremental conduction. Now, what is decremental conduction? You all must be knowing that there is always a delay of the impulse in conduction within the AV node. That's why you are getting the PR segment. The PR segment represents the AV nodal conduction, which is always delayed. This delaying of conduction of impulse from the atrium to ventricle to the AV node is explained by this phenomenon that is known as the decremental conduction. This is happening because the gap junctions are very sparse in the AV node. The gap junctions are primarily formed because of the connection channels. The exact name I am not able to recollect. So it is connection channels, you can remember. Okay. So this is known as the decremental conduction. Now with these basics, we will see what are the disorders, what are the conditions which will affect the AV node. As you all know that AV node, whenever you increase the parasympathetic supply to the AV node, that means whenever you are increasing the vagal supply or the cholinergic supply, always there is a decrease in the AV nodal conduction. And whenever you are increasing the sympathetic supply, there is increase in AV nodal conduction. So what are the etiologies that can affect this AV node? Okay. Now autonomic causes, these include the carotid sinus hypersensitivity or any vasovagal condition. These two conditions will cause increase in vagal tone, that cause reduction in impulse conduction in the AV node, and that can result in a syncopal episode. What are the metabolic conditions? Metabolic conditions include hyperkalemia and hypermagnesemia. Remember, hypokalemia, I have already told you, hypokalemia causes QT prolongation and ventricular tachycardia. Hyperkalemia will have a predominant effect on the AV node, and it can cause AV nodal blocks. Okay. Similarly, hypermagnesemia also. Endocrine conditions include hypothyroidism and addisons. All of them actually reduce the conduction in the AV node. Whatever I am discussing in this etiology part, actually all of them actually cause a defect in the AV node or reduced conduction in the AV node or some kind of AV blocks. Drugs, you must be familiar with the beta blockers, the calcium channel blockers, calcium channel blockers. Then we have the antiarrhythmics, especially 1 and 3, 1 and 3. Then digoxin has vagomimetic effect, and also lithium. So all these drugs can cause AV nodal conduction blocks. Infection, among the bacterial infection, we have tuberculosis, we have diphtheria, we have syphilis, we have Lyme's disease. Among the parasitic causes, we have toxoplasma, and also we have Chagas disease. So these are the important infections that you have to remember which can cause AV nodal blocks. Infiltration, very simple, amyloid, sarcoidosis or sarcoidosis, or hemochromatosis. Inflammation usually include the connective tissue disorders, especially SLE, RA, systemic sclerosis, mixed connective tissue disorders. Neoplasms were trauma. These include lymphomas, mesotheliomas. Trauma, you can remember radiation or any kind of radiofrequency ablation can cause AV nodal blocks. Coronary artery disease, I have already discussed that MI, especially the inferior MI, around 20% of cases are associated with some kind of AV nodal blocks. Heritable or congenital disease, first one is congenital heart diseases. There are many examples, ASD, VSD, endocardial cushion defects. So all of them can cause AV nodal blocks. Then maternal SLE. It is notorious to cause complete heart block, which we will be discussing in the rheumatology section. Then Burns-Shire syndrome. It's a mitochondrial myopathy. Then we have some of the muscle dystrophies like myotonic dystrophy, facioscapulohumeral dystrophy. And the final one is progressive familial heart blocks involving chromosome 1 and 19. So these are all the etiologies that can cause AV nodal conduction blocks. Now coming to the first, so AV nodal blocks are 3 types. Previously also I have mentioned somewhere there are 3 types: first degree, second degree, and third degree. Second degree is divided into type 1 and type 2. So first we'll start with the first degree AV block. First degree AV block. When we're discussing about the PR interval, I have told you whenever there is a prolongation of the PR interval, that is actually a characteristic feature of AV block. So this is characterized by PR prolongation. That's all. PR prolongation. And I have told you that normal PR interval is 3 to 5 small boxes, or 120 to 200 milliseconds, because one small box is 40 milliseconds. So 3 to 5 small box, or 120 to 200 milliseconds. So anything more than 200 is known as the first degree heart block. Now, as you can see here, if you see here, so this is a P wave shown here. This is a P wave, and this is the PR interval. Definitely, this is more than 5 small boxes. So this is the case of first degree heart block, and it's a very severe type of first degree heart block because the P wave is the QRS complex is so much delayed that the P is coming almost near the T wave. So this is a very severe type of first degree heart block. Next we'll see here. Remember, now we have started studying about the kinds of arrhythmia. Now this is type of bradyarrhythmias, and later we'll be studying about the tachyarrhythmias. Now, before these whatever lectures I have taken, I have not focused much on the rhythm strip. Okay, I have always used mostly the 12 lead ECG, and I have shown the findings. But remember, from now on, like whenever we are going to read about the arrhythmias, maybe it be brady or tachyarrhythmias, now the importance of rhythm strip is very now now the rhythm strip is very important to look for. So that's why you will get a rhythm. Always the rhythm strip will be at the bottom of the ECG. So if you have a 12 lead ECG, you may have a rhythm strip at the bottom. Okay, so always you have to look at the rhythm strip to find out the arrhythmias. And I have already told you why lead 2 is known as the rhythm strip, because the axis, normal axis, the lead 2 vector is in accordance with the normal axis of the heart, that is around 60 degree. As you can see here, uh, this is the PR interval. This is the PR interval, and this is around uh, P for around 7 to 8 small boxes, 7 to 8 small boxes, 7 to 8 small boxes. So this is the case of first degree heart block. Now coming to second degree heart block. So now we'll start with second degree heart block. Second degree heart block. Now second degree heart block, there are two types, type 1 or type 2, that is known as Mobich type 1 and Mobich type 2. First, we'll start with Mobich type 1. What happens in Mobich type 1? This is also known as Munkeh wave phenomenon. In Mobich type 1, there is the PR prolongation is progressive. There is progressive PR prolongation. And this will lead to ultimately there will be a non-conduction of impulse. So there will be progressive PR prolongation, successive progressive PR prolongation, and ultimately it will lead to non-conduction of the impulse. We'll see the ECG and then we will be able to understand more. What happens in Mobius type 2? There is no progressive PR prolongation. No progressive PR prolongation. But there is intermittent non-conduction of impulse. Non-conduction of impulse. Non-conduction impulse. What do you understand by non-conduction impulse? That means you will have the P wave, but it will not be followed by a QRS complex. That means the impulse from the atrium is not getting conducted to the ventricles. So you'll have a P wave, but it won't be followed by a QRS complex. That is known as non-conduction of impulse. Now, from this, if you are not familiar with these stuffs, you might be thinking that Mobius type 2 is better because there is no progressive PR prolongation. It's just the intermittent non-conduction of impulse. But in case of Mobius type 1, you have PR prolongation, along with that you are having non-conduction of impulse. But let me tell you that Mobius type 2 is much more dangerous than Mobius type 1. Okay, Mobius type 2 is much more dangerous than Mobius type 1. Now, how is this possible? Now, for that, you need to understand what is the mechanism behind these two. For Mobius type 1, the conduction block is inside the AV node. Okay. And here it is a functional block. Here it is a functional block. So because it is a functional block, the AV node will get fatigued with each conduction of impulse. So because of that fatigue, it will have a progressive PR prolongation. So because it is a functional block, the AV node will get fatigued. And because of that fatigueness, it will have progressive PR prolongation, that is progressive delay of conduction through the AV node with each impulse. And ultimately, it will lead to a non-conduction of the impulse. Okay, so it will get fatigued. That is the reason you are having a progressive PR prolongation. And ultimately, it will be severely fatigued, and at that point of time, it will not be able to conduct the impulse. And that's why you will get a non-conduction of impulse. But what happens in Mobius type 2? In Mobius type 2, the block is below the AV node, that is bundle of His. Most likely it is bundle of His or below. It is below the AV node. Okay. And this is not a functional block. This is a structural block. Now this is important. This is a structural damage or structural block. This is not functional. This is structural. Okay. Because type 1 is functional block, it is easy to treat, and most of the times it is reversible also. But type 2, because there is a structural block, most of the times it may not be reversible, and it can go to higher order blocks. Okay. So because there is a structural block, there is no concept of fatigue. Fatigue concept is not there, but fatigue concept is there in the type 1 because it's a functional block. In case of type 2, it is a structural block. There is no concept of fatigue. Here the concept is all or none. So either they will conduct properly or they will just stop conducting. Okay, that's why in type 2 you will not get a progressive PR prolongation, but there will be intermittent non-conduction of impulse. And in type 1 you will get a progressive PR prolongation and non-conduction of impulse. I hope it is clear. Okay, so that's why type 2 is more dangerous than type 1. I will see the ECGs, this below ECG you can see here. This is the peer interval 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 here. And next you can see there is a P wave. Of course there is a P wave, but there is no QRS. As you can see here, this peer interval, this peer interval, this peer interval, this peer interval, you can see there is a gradual prolongation, and ultimately there is a non-conduction of impulse. Okay. Now, in case of type 2, what will happen? Uh, all these peer intervals will be equal, and there will be a non-conduction of impulse. The best way to identify whether it's a type 1 or type 2, whenever you have confusion, you have to look for the peer interval that is preceding the non-conducted impulse and the peer interval following the non-conducted impulse. You can see this is the preceding peer interval, which is more, and this is the following peer interval, which is less. Of course, there is a discrepancy. So this is seen in case of type 1 or Mobius type 1 block. And if both are same, if both these intervals are same, then it will be type 2 block. Okay, so always, if you have confusion, always look at the peer interval, which is preceding and following the non-conducted impulse. Now, this is a feature you'll find in this type 1 blocks. This is known as group bitting. Here you can see there is no non-conduction of the impulse. Here you can see there is a P and QRS definitely. Here you can see peer is getting prolonged. Here more prolongation, and again there is non-conduction. So this is a group. Similarly, the next group. Similarly, the next group. Okay. So this is known as group bitting. Okay. So if you are not able to understand, just look at the ECG again and try to understand it by yourself. It's not very difficult. So group bitting, just remember the name. Group bitting is a feature of type 1 block. Mechanism I have already told you, so I am not going to repeat it again. So it is AV node. The site of the program is an AV node, and this is a functional block. This is a functional block. That's why the AV node will get fatigue, and this fatigue is responsible for prolongation of peer. And whenever there is a severe fatigue, it will lead to non-conduction of the non-conduction of the impulse. Clinical significance is, I told this is a benign condition. This is a benign condition, and rarely pacing is needed. Very rarely pacing is needed. It's a benign condition because it's a functional block. If you will treat the underlying cause, most of the times it will settle. Now we'll see one more example. Here, always look at the rhythm strip. You can see the peer interval here. You can see the peer interval here. You can see there is gradual progressive of peer interval, and there is a non-conduction of impulse here. Also, you can appreciate there is a group bitting. One more point I told: always look whenever there is a non-conduction impulse. Always look the preceding peer interval and the following peer interval. You can find that there is a significant discrepancy. Now, what is this? Now you can see that there is a P wave here. There is a P wave here. There is a P wave here. Here there is a P wave. Here there is a P wave. Here there is a P wave. Here also there is a P wave. So from this you can understand what is the rate of atrial rate. First of all, we will see what is the atrial rate. Then we'll see what is the ventricular rate. Atrial rate comes from the P waves intervals. So it is around 1, 2, 3. Three large boxes. Yes, 3 large boxes. So atrial rate is around 100. 300 divided by 3, around 100. You see the ventricular rate 1, 2, 3, 4, 5, 6. So around 6, 300 divided by 6 will be around 50. So atrial rate is 100, ventricular rate is 50, and you can clearly see that only alternate P waves are getting conducted. Alternate impulses are being conducted, and that means for this P wave there is no Q wave. Again for this P wave there is no Q wave. Again for this P wave there is no Q wave. That means only alternate impulses are being conducted, and alternate impulses are not being conducted. This is known as 2:1 block. 2:1 block. Now in this condition, it is very difficult to tell whether it is a Mobius type 1 block or type 2 block, because we are not able to find the progressive prolongation. Because it's a 2:1 block, we are not able to find the progressive prolongation of the peer interval. Okay, so now in this ECG, it is very difficult to tell whether it is a type 1 block or type 2 block. But however, It is not all cases you will be able to tell, but in some cases you might think it is more likely type 1 or type 2. I'll be discussing that later. Okay, after telling you about the type 2, I'll be telling about this ECG and what is the most likely diagnosis. Okay, most likely, but you cannot tell 100% that this is type 1 or type 2. Now coming to type 2, I have already discussed the concept behind it. You can see the peer intervals. If you look at the peer interval is constant. Peer interval is constant, and here there is a non-conduction of impulse. Okay, and this is due to damage. This is due to damage to the structure below AV node. So below AV node, most of the times it is bundle of his. Most of the times it is bundle of his or below, bundle of his or below. And I told it is a structural damage. It is a structural damage. There is no concept of fatigue. There is concept of all or none. Concept of all or none. Either they will conduct or they won't conduct. Now, if there is a block at the bundle of his, if there is a block at bundle of his, you will get a narrow QRS complex. You will get a narrow QRS complex. Narrow QRS complex. If you are having a block below bundle of his, you will get a wide QRS complex. Wide QRS complex. Okay. So AV node and bundle of his, actually this is known as the junction. This is known as junction. If the block is at bundle of his, if the block is at bundle of his, it will produce a narrow QRS complex due to junctional escape. I will be telling about the junctional escapes. But if the block is below the bundle of his, you know that below bundle of his you are having the bundle branches. So if the block is in the bundle branches, you will have a wide QRS. This concept we have already discussed long back in the previous lectures in the bundle branch block section. I have already told whenever there is a bundle branch block, you will get a wide QRS. Okay, and remember this is more important. This is more important. So around 75% of the cases of type 2 block, movies type 2, you will get wide QRS complex. Around 25% of the cases will get a narrow QRS complex. Okay, so this is more common. This is more common. Clinical significance is this is dangerous. This is dangerous rhythm. This is dangerous rhythm. The more below you come, the more dangerous it will become. So if you are getting a wide QRS, if you are getting a wide, especially the wide QRS variety, is much more dangerous. Especially the wide QRS variety, because here the block is below the bundle of his. Now there is a high chance of this going into a higher degree block or a complete heart block. Higher degree block or complete heart block. This requires treatment. Most of the times needs pacing. Most of the times needs pacing. It may be temporary pacing or it may be permanent pacing, depending on what is the underlying reason. If you see here, look at the rhythm state. This is the P wave here. This is a P wave here. This is a P wave here, but there is non-conduction of the impulse. And you can see the PR interval. This is the PR interval. This is the PR interval. They're all same. So this is a case of obese type 2 block, and you can always appreciate that here the QRS complex is wide. Here the QRS complex, you can see the QRS complex is wide. QRS complex is wide. One very important concept I must tell you that whenever you are getting a wide QRS complex, you always try to find out what kind of bundle branch block it mimics. What kind of bundle branch block it mimics. So if you see here there is a predominant negative wave in the V1. It's a predominant negative wave in the V1 and a predominant positive wave in V6. That means it is following a pattern of William. So that means it is left bundle branch like morphology. Remember, whenever you are not sure about the bundle branch block, you have to tell like morphology. So this is the LBBB like morphology. LBBB like morphology. Okay. So now what is the significance of that? I'll be telling later. Just remember, whenever you are getting a wide QRS complex, you always try to find out what kind of bundle branch type morphology. Significance of this I'll be telling in the subsequent slides or maybe in the subsequent lectures. So that's why I must tell one thing, that you have to see the bundle branch block lecture. If you have not seen, you have to see it and you have to be very thorough in that concept, because as we read more and more about the arrhythmias and the ventricular rhythms, it will be very difficult to understand if you don't know about the bundle branch block morphologies. Okay, and I have already discussed about the WPW. In that also, you must be remembering that you have to know the bundle branch block morphology to find out the type of WPW, whether it is a type A or type B WPW. Okay, so always, whenever you are getting a wide QRS complex, always try to find out what kind of bundle branch block morphology. So here, in this case, we'll see here again. In this case, you look at the PUF. This is the PUF. This is the PUF. This is the PUF. And definitely there will be a PUF hiding inside this T wave, which is not visible here. Again, this is a PUF. This is a PUF. This is a PUF. So from this, you can understand that what is the rate of the P wave. It is around, if you see, around two large boxes. So atrial rate is around 300 divided by 2, around 150. Ventricular rate, see the ventricular rate. This is the RR interval. Sorry, this is a QRS complex. This is a QRS complex. So if you see here, 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9, 300 divided by 9. So it will be around 40, 45. It will be around 45. It will be around 45. So as you can see here, there are 4 P waves but 1 QRS complex. 4 P waves with 1 QRS complex. So this is known as 4:1 block. 4:1 block. It's known as 4:1 block. And this is a high grade block. This is a high grade block. High grade block. Okay, this is a high grade 4:1 block. Here you need not mention whether it's a Mobius type 1 or type 2 block. You can just tell high grade block. It's a 4:1 block. So fixed ratio block, I have already discussed about this 2:1, 3:1, 4:1 block. Fixed ratio block can be result of either Mobius type 1 and type 2, and it's always sometimes it is very difficult to tell whether it's a Mobius type 1 or type 2 block if you do not have the previous ECGs. So this is again a 2:1 block which I have already shown on previous ECG also. As you can see here, this is a P wave and there is a QRS complex following. Again, this is a P wave but there is no QRS. This is a P wave, there is a QRS. This is a P wave but there is no QRS here. This is a 2:1 block, and I have told you that whenever you are getting a 2:1 block, it is difficult to differentiate whether it is a Mobius type 1 block or it's a type 2 block, because the progressive prolongation of PR that you classically seen in type 1 that you will not be able to appreciate here. So, so how to differentiate? But what you can see here, the QRS complex morphology. The QRS complex morphology, it is narrow. It's a narrow QRS complex morphology, and I have told in case of Mobius type 2. Around 70% of the time it is wide QRS complex. Okay, but 20% of the time it can still be narrow QRS, but 75% of the time it is wide QRS complex. Okay, so this ECG is more likely to be type 1 than type 2, but type 2 is still possible because 25% of the cases you may get 25% of the cases you may get a narrow QRS complex. This is a 4:1 block, so I'm not going to discuss it again. Mobius type 1 and type 2, I have already told you, you have to look for the QRS complex. If it is narrow, as we have seen in the previous image, if it is narrow, more likely, type 1 is more likely, but you cannot tell with 100% confidence that this is type 1 because type 2 is also possible, but this is a pointer. Remember, QRS interval is a pointer for type 1 type 2. Now coming to the third one, this is the third degree AV block, or you can tell it's a complete hard block. That means here the AV node has stopped functioning. So AV node has stopped functioning. Completely it has stopped functioning. That means it will not transmit any impulse from the atrium to the ventricle. It will not transmit any impulse from atrium to the ventricle. So if it is not transmitting, so how the ventricles will function? Now the impulse for ventricles may originate from the junction, that is the bundle of his, that is below the block, that is known as junctional rhythm, or the impulses may originate from the ventricles. Impulses may originate from the junction, that is the bundle of his, or impulses may originate from the ventricles. Now these will control the ventricular contraction. Now if the impulse is originating from the junction, that is known as junctional rhythm, and here the QRS will be narrow. But if the impulse is originating from the ventricles, here the QRS will be wide. So in case of complete heart block, In case of complete heart block, if you are getting a wide QRS complex, it is the ventricular rhythm. In case of a complete heart block, if you are getting a narrow QRS complex, it is the junctional rhythm, which is junctional rhythm. And what else you can appreciate that the P waves will follow their own pattern, and the ventricular the QRS complexes will follow their own pattern. So there will be complete AV dissociation. There will be complete AV dissociation. Okay, so there is AV dissociation. As you can see here, there is a P wave 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 here, and the P wave rate is around 1, 2, 3 small boxes. So atrial rate is around 100, 300 divided by 3, and ventricular rate you can see 1, 2, 3, 4, 5, 6, 7, 8, around 8. So ventricular rate, so 300 divided by 8, so it will be around 50. It will be around 40 to 50. It will be around 40 to 50. Okay, so there is complete AV dissociation. The QRS complexes, they are happening at their own speed, and the P waves are coming at their own speed. Okay, this thing I have already told you. Now you can see this is having narrow QRS complex. Complete heart block is narrow QRS complex. So this is junctional rhythm. Okay, here the escape rhythm is junctional rhythm. This is AV block with wide QRS complex. So here the escape rhythm is ventricular escape rhythm. That means the ventricles are producing the impulses. So normal usually the pacemaker of the heart is SNO because it has the highest rate. It has the highest rate, and the junction will have a rate of 40 to 60. The ventricles will have a rate of around 20 to 40. So ventricles have a very low impulse generation rate. So ventricular rate will be around 20 to 40. Anyway, we'll be discussing that again. Here also you can see there is a complete AV dissociation. They have already shown these arrow marks are showing the P waves, and these are showing the P waves and the rate of the atrial rate. Atrial rate we will find from the P waves. You can see there are around 1, 2, 3, 3 small boxes. Atrial rate is around 100. For ventricles, so this is the RR interval. 1, 2, 3, 4, 5. So around 5 small boxes. 300 divided by 5 around 60. So ventricular rate is around 60. And you can see the QRS complexes are wide. QRS complexes are wide. That means it's a ventricular escape rhythm. Ventricular escape rhythm. Okay, it is not junctional escape, it's a ventricular escape rhythm. But what I have told, ventricular escape rhythm means the heart is the ventricles are functioning because of the impulse generated from the ventricle itself. I have told that normal physiological ventricular impulse generation rate is around 20 to 40. Now this is confusing. This is confusing because I told ventricles will produce a rate at around 20 to 40, but here the ventricular rate is 60. So you might be thinking that this is junctional rhythm. No. So this is known as AIVR. AIVR, that is accelerated idioventricular rhythm. Accelerated idioventricular rhythm. So whenever the ventricular rate is 40 to 100, whenever the ventricular rate is more than the ventricular escape rhythms is showing a rate of 40 to 100, it is known as accelerated idioventricular rhythm. If the rate is more than 100, that is ventricular tachycardia, that we will be discussing later. But as of now, remember, if this is a complete heart block, that is the first thing that you have understood. The next concept is what kind of escape rhythm this is showing. This is showing ventricular escape rhythm because the QRS is wide. Okay. Then what is the rate of the ventricular escape rhythm? The rate is 60. The rate is 60 means definitely it is more than the normal physiological ventricular impulse generation rate. So that is known as accelerated ventricular rhythm. Okay, accelerated ventricular rhythm or accelerated idioventricular rhythm. Okay, I hope it is clear now. Now the next point is, I have told whenever you are getting a wide QRS complex or ventricular rhythm, you have to always look for what kind of morphology it is. As you can see here, the V1 it is positive and it is showing M pattern, and V6 it is predominantly negative. So this is marrow pattern and this is marrow pattern. That means it is RBBP like morphology. RBBP like morphology. One more concept I will tell you now. If the ventricular escape rhythm is showing right bundle branch like morphology, the origin of this ventricular impulse is left ventricle. Origin of this ventricular impulse is left ventricle. From this ECG, I can also tell you whether it is originating from the left ventricular outflow tract or left ventricular base. or like the lower part of the left ventricle, whether it is originating from the lower part of the left ventricle or from the upper part of the left ventricle. That also I can tell, but I will not be telling you now because it will be more confusing. For the time being, you remember you have to always look for the morphology whenever there is a white QRS complex or ventricular rhythms. So here you can find it's a RBBB like morphology. That means the impulse is originating from the left side, left ventricle. More on this anyway we'll be discussing when we'll discuss about the ventricular rhythms and ventricular arrhythmias. But for the time being, you remember. Okay. So this is always like so fascinating that a simple ECG, one ECG strip, a 12-bit ECG strip can give you so much information about the heart. Okay. It can give you so much information about the heart. So in this particular ECG, you can find that there is a complete heart block, there is complete AV dissociation, there is ventricular escape rhythm at a rate of around 60. So it is accelerated idioventricular rhythm. The ventricular escape rhythm is originating from the left ventricle because the morphology is right bundle branch like morphology. Here also you can see white QRS complex. You can see the ventricular rate is around 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So 300 divided by 11, 300 divided by 11, ventricular rate. So it will be around around 27. It will be around 27. So this is the proper ventricular escape rhythm. Proper ventricular escape rhythm. Here again you can see this is the P wave here. Here there is a P wave buried inside it. Here there is a P wave. Here there is a P wave. Here there is a P wave. So P waves are happening at their own pace. That is around like 1, 2, 3, 3.5. So it will be around 100 or 300, around 80. Atrial rate is around 80. Ventricular rate 1, 2, 3, 4, 5, 6, 7. So 300 divided by 7. So it will be around 300 divided by 7. So 7 around 42. Ventricular rate is around 42. This is also a one more thing. Next point is this is definitely a complete heart block. So there is complete AV dissociation. This is complete heart block, and you can see the QRS complex is narrow. QRS complex is narrow. So this is junctional rhythm. This is junctional escape rhythm, and normal junctional rate is around 40 to 60. Around 40 to 60. So this is a normal junctional rhythm escape. Junctional escape rhythm. Now, so okay, so before I'll tell about the diagnostic testing, I'll just tell about the junctional escape rhythm, which I've already discussed. Junctional escape rhythm, I've already discussed. This is the normal junctional escape rhythm. The rate is around 42. Rate is around 40 to 60. So anything from 60 to 100, this is known as accelerated junctional rhythm. That means in the previous ECG, what I have told, the rate was 42. Complete heart block, narrow QRS means it's a junctional rhythm. Then you look at the rate of ventricular rate. Ventricular rate is 42. That means it's a normal junctional escape rhythm. If the rate would have been something like 80, ventricular rate is 80 and you are getting narrow QRS. So narrow QRS defines that it's a junctional escape. And if the ventricular rate would have been 80, then you would have called it as accelerated junctional rhythm. And if it is more than 100, then you have to call it a junctional tachy. Junctional tachy. All these things again we'll be discussing in the tachyarrhythmias. Now this is a very interesting ECG. If you see here, the V1 is shown here. As you can see, it's a, like fluttering waves or fibrillating waves. Okay, these are fibrillating waves which are shown in V1. Okay, so this is a case of atrial fibrillation. Anyway, we'll be discussing about it in the tachyarrhythmia section. If you are not able to identify, it's fine. It's a case of atrial fibrillation. But the most striking finding that we can get in case of atrial fibrillation, you all must be knowing that you will always get a irregular heart rate. But if you see here, this is a QRS complex, 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 this is a QRS complex. So that means we are getting QRS complexes at a regular interval. So this is known as regularized AF. Regularized AF. So that means this patient is having AF, but along with that, this patient is having junctional rhythm. Okay, so QRS complexes are narrow, and if you want to look for the ventricular rate 1, 2, 3, 4, so it will be around 75. Ventricular rate is around 75. So kind of you can tell junctional tachy. So this is junctional tachycardia. Sorry, sorry, accelerated junctional rhythm, accelerated junctional rhythm. Okay. So whenever you are getting AF, you should be expecting a irregular QRS complex, but here you are getting regular QRS complex. That means it's a regularized AF. Why this is happening? If the AF is associated with a complete heart block, if it is associated with a complete heart block, you may get junctional escape or ventricular escape rhythm. In those conditions, you will get a regular heart rate, regular QRS complex if you have a junction, because here these QRS complexes are not dependent on the conduction from the atrium. Okay. So AF with complete heart block, you will get a regularized AF, and this is a classical this is a classical ECG which is seen in digoxin toxicity. Is seen in digoxin toxicity. Okay. So all these things are written here. So I'll just put it. So all these things are written here. Whatever I'm saying, it's a regularized AF, and this is classically seen in digoxin toxicity. So AF plus complete heart block, and this is a junctional rhythm, and the junctional rhythm type is, the rate is around 70, so 75, so type is accelerated junctional rhythm. This I have already discussed. Junctional brady means junctional rhythm, but rate is less than 40. Junctional escape rhythm is 40 to 60. That is, this is the normal junctional rhythm rate. Accelerated junctional rhythm is more than 60, but 60 to 100, up to 60 to 100. Junctional tachy means more than 100. Junctional rhythm with rate of more than 100. Ventricular escape rhythm, which I have already discussed, the normal rate is 20 to 40. 40 to 60 you can tell as accelerated idioventricular rhythm or accelerated ventricular rhythm. More than 100, that is ventricular tachycardia. And of course, you will have a wide QRS complex. Wide QRS complex. Okay, so as you can see here, these are wide QRS complexes. And if you see the rate will be, you can see here 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So around 300 divided by 13. So around 23. So this is ventricular rhythm. And if you want to look for the morphology, you can see there is a predominant negative wave in V1. That means it's a LBBB morphology. LBBB morphology. So definitely you can tell the origin of impulse is right ventricle. Origin of impulse is right ventricle. So this also you can look, this complete heart block is ventricular escape rhythm. So there is nothing new. You can just look at these ECGs and you can learn. Now what I have left is the diagnostic testing. This part is given in Harrison. This. So remember, when you do vagal maneuvers, the conduction through the AV node, decreases. Conduction through the AV node decreases. What you need to remember is the AV node is responsive to the vagal maneuvers, but infranodal system, this is not very sensitive to vagal maneuvers. This is not very sensitive to vagal maneuvers or autonomic maneuvers. Okay. So this point is very important. So if you give atropine, which is an anticholinergic drug, atropine, opposite effect of that of vagus, or you are giving a adrenergic drug, that is isoproterenol, or you increase the sympathetic activity physiologically, that is through exercise. All these things can increase the conduction, through AV node, increase conduction through AV node. But again, it will have a less effect on the infranodal conduction system. Okay. So vagal maneuvers, that will reduce the conduction through AV node, and the opposite of vagal maneuvers, that is either anticholinergics or adrenergics, or physiologically increasing the sympathetic stimulation, can increase the conduction through AV node. What happens in congenital complete heart block? In congenital complete heart block, most of the times you will get a junctional escape rhythm, so you will have a narrow QRS complex. So here the block is somewhat higher up in the junction, somewhat higher up inside the AV node. But in case of acquired complete heart block, most of the times you will find a ventricular escape rhythm. That means here the block is slightly below. Okay. So here the block is slightly below. In case of congenital complete heart block, the block is higher up. So that's why you are getting a Junctional escape, which has a normal or narrow QRS complex. In case of acquired complete heart block, this is a much more dangerous condition. Here you will get a block slightly below, and this will produce a wide QRS complex that is due to the ventricular escape breathing. Now that's why this congenital complete heart block, they will respond to exercise or other autonomic maneuvers. But this acquired complete heart block, they will not respond to exercise. They will not respond to exercise. Now the next point that you have to remember is his bundle electrocardiogram. His bundle electrocardiogram. What is his bundle electrocardiogram? Now how you take this ECG? You have to put the catheter. You have to put the catheter at the superior margin of tricuspid valve annulus. Tricuspid valve annulus. So remember the tricuspid valve annulus is the anterior margin of the triangular valve. Okay, so we put the catheter at the superior margin of the tricuspid valve annulus, and then you take the His bundle electrocardiogram. This has two components. One is AH interval, another one is HV interval. AH means from atrium to the bundle of His. So this includes the conduction through the AV node. HV interval means it is the conduction from bundle of His to the first ventricular response. So this is actually telling us about the conduction through the bundle of His. So any evinodal pathology, this AH interval will prolong. Any infranodal pathology, this HV interval will prolong. And the normal values you have to remember, it is less than 130 milliseconds. The AH interval and HV interval is less than equal to 55 milliseconds. Okay, I hope it is clear. AH intervals include AV node because it is the conduction from atrium to the bundle of His. HV interval is conduction from bundle of His to the first ventricular response. So that includes the conduction of bundle of His. So any AV nodal, the nodal pathology, it will increase the AH interval. Any infranodal pathology, it will increase the HV interval. So this His bundle electrocardiogram is done to differentiate whether the block is at AV nodal level or it's at infranodal level. Okay. And also exercise also to some extent can sometimes differentiate the blocks, whether it is through the AV node or it is through the or the block is in the infranodal system, because vagal maneuvers or exercise will have effect if the AV node is involved, but in case of infranodal involvement, it will not have any effect. Treatment of this kind of blocks, AV nodal blocks, you have to treat the cause. I have already discussed what are the causes. You have to treat the cause. That's the first thing. Second thing is you can give a trial of drugs whenever required, atropine or isoprenylene. Or the most important one is pacing. Okay, these are the tables from Harrison that they have given the recommendations for pacemaker implantation in cases of acquired AV blocks. So these are slightly difficult to remember. So if you want to remember, at least you remember the class 1 indications. Okay, in his like how I remember is whenever it is symptomatic, you have to go for pacing. That is one point you have to remember. Then if you want to remember in detail, you can already remember all these points, but it is very difficult to remember. So that's why I put the image here. And so if you want to read it, you can read and remember. These are the class 1 indications. Similarly, there are certain other class 1 indications for pacemaker implantation in cases of in cases of acute MI, and also indication of pacemaker in case of chronic bivascular trifascicular blocks. If you want to remember, you can remember these class 1 indications. This is just an image showing the like how the pacing is done. There are two types of pacing. One is the transcutaneous pacing, as you can see here. You can place the pads either both the pads you can keep anteriorly, or you can keep one pad anteriorly and one pad posteriorly. So this is types of transcutaneous pacing. This is type of transvenous pacing. This is a transvenous pacing where you have to go through the internal jugular vein, then you have to go into inside the heart, and you have to do the pacing. Okay, so this is a very interesting. Remember, most of the cases they will not respond to the transcutaneous pacing if the condition is serious. If you are not able to treat the underlying cause, transcutaneous pacing is just a temporary thing and it will not sustain for a longer time. So many of these patients where there is a associated condition which is causing it to have a significant block, many of the times we have to go for transvenous pacing. Okay, this is a very beautiful exercise to do the transvenous pacing that we have done during our residency. So that's all about the AB nodal blocks. So next we'll be studying about the SA nodal disorders. Then we'll be going to the tachyarrhythmias. So I hope this is useful for you. If you like it, so definitely write in the comment section. If you have any suggestion, write it in the comment section, and also share with your friends, and also join the Telegram group for the PPT of this lecture. So thank you everyone.